Hello, I'm Jacob Dole here at the American Heart Association National Conference talking with Dr. Stephen Wiviott from Brigham and Women's Hospital about the results of their recent dual antiplatelet therapy trial, or DAPT trial. Dr. Wiviott, the main results were presented by your colleague Dr. Laura Mori yesterday and compared the outcomes of patients treated with 12 months versus 30 months of dual antiplatelet therapy. Would you mind briefly summarizing the results for that trial for us?
Sure. Yeah, so this was an interesting trial that allowed for the investigator to choose the type of stent and the type of drug that they wished to use for patients who were treated with coronary stenting. And it was an inclusive trial that included both acute coronary syndrome patients and patients who had elective stenting. So what the trial was 12 months on therapy. If the patient did well without clinical events for those 12 months and agreed to be randomized, then they were randomized to either continuation of the dual antiplatelet therapy they were taking or discontinuation, and the primary endpoint was at 30 months. And it showed with the primary, there were two co-primary endpoints. One was stent thrombosis, and the other was a composite of major adverse cardiac and cerebrovascular events. Both showed significant reductions in terms of the stent thrombosis, a reduction of almost around 70%, and with the MACE event, or the major adverse cardiac events, a reduction of about 30%. Both were highly statistically significant. As would be expected with prolonged antiplatelet therapy, there was also an increase in bleeding associated with that, an increase predominantly driven by gusto moderate bleeding. And as was highlighted in the presentation, and we may discuss more, there was a tendency toward a higher rate of overall mortality in the trial.
I would like to get to that in a few moments, but I think in general these are exciting results, and for patients who qualify or who have reached 12 months of therapy, it may be the longer therapy is better. However, the trial design was interesting in that over 25,000 patients were initially enrolled at the time of their PCI, though fewer than 10,000 were ultimately randomized for the reasons that you mentioned. They had to make it to 12 months. How do you think that influences the generalizability of this study, and which patients we should consider to treat with this strategy?
Yeah, so it's a good observation. I think it actually, in some senses, to me, increases the generalizability of this question, because we don't, at the time we place a stent, say this patient must be on drug for 30 months, or I think this is a patient who should only be on for 12 months. We make that decision at 12 months. Is this the time that we should stop, or is there a reason to continue? So I think that many patients who have stents will have problems in the first 12 months. They may bleed, and you wouldn't wish to treat with longer-term therapy. They may have recurrent cardiovascular events that would require additional stenting, or might be a spontaneous myocardial infarction. And you may wish to continue longer-term antiplatelet therapy. So I think the question really is relevant to those people who are doing well at 12 months, where it's not clear what to do. And so I think that the number of patients who dropped off, many were for events, and I think that is as we just discussed. And there has been some strong opinions in this area, which is a great reason to do clinical trials. But some people have felt it was unethical to stop at 12 months. Some people felt, how could you possibly go past 12 months? And so many investigators and patients had strong opinions and didn't wish to be randomized. But the fact that there's strong opinions on both sides, I think, makes this a very relevant question. And so in my mind, because you're making the decision at 12 months, those are the patients who you're really considering this in.
There appeared also, even for patients who continued dual antiplatelet therapy through 30 months, this trial actually looked out to 33 months to see what occurred after they stopped that therapy. And there did seem to be an increasing rate of ischemic events after 30 months. Do you think, theoretically, this could give some evidence that patients should be on lifelong or indefinite therapy?
Yeah, so that's a good observation. I think that in the presentation and in the paper in the New England Journal of Medicine, there is a notation that even at 30 months, there seems to be an increasing rate of cardiovascular events at the time of discontinuation of study medication. This was particularly prevalent in one of the component studies that looked at paclitaxel-eluting stents and had patients treated with prasugrel, where there was actually a DSMB action about that. We don't have enough data from the trial to have statistical proof that this is a concern. But I think that 30 months is a relatively arbitrary time point. The curves seem to be diverging at the period of 30 months, and with this concern of a potential loss of protection, and I'm careful not to use the word rebound, but where events begin to accrue again at 30 months, it does seem reasonable that if you're going to treat a patient for long term, that you may wish to continue beyond that.
Great. And as you mentioned before, the co-primary endpoints were both in favor of continued therapy up to 30 months. Within the composite endpoint of major cardiovascular and cerebrovascular events, the endpoint was driven by MI events, and these were both stent thrombosis-related MI and non-stent thrombosis MI. However, mortality did not go in the same direction. In fact, as you mentioned, the treatment group that received continued antiplatelet therapy did have higher event rate of mortality. Can you discuss for a second the breakdown of those deaths and whether you believe that is something that we can mechanistically describe, we can explain from the use of dual antiplatelet therapy, or is this perhaps a chance finding?
Yeah, so I think in any trial that you conduct, mortality is important. I mean, ultimately, that is the hardest of all clinical endpoints. Certainly, a trial like this was not designed as a mortality trial, nor powered for mortality. But what was observed was that, as you said, that mortality seemed to go in the wrong direction. When broken down, cardiovascular deaths were about even between the two treatment arms, but there was a higher rate of non-cardiovascular death in the continued dual antiplatelet treatment arm. And so when that finding was observed, to their great credit, I think the trial group went back and really looked in great detail both at the types of deaths and what was known about cardiovascular and non-cardiovascular mortality in this space of dual antiplatelet therapy. And to me, I think the strongest suggestion that this could be the play of chance is from a large-scale meta-analysis that was performed that was also published simultaneously with the presentation in The Lancet, showing that in about 70,000 patient years of data, 70,000 patients with more than 100,000 years of data, that there did not seem to be a signal for either total mortality or non-cardiovascular mortality. It's also the case that in the bare metal stent group, the part that we were discussing, the primary portion of the trial was all drug-eluting stents. In the bare metal stent group, which was a smaller group of patients, there was also no mortality signal in a concurrently treated population. So to me, the fact that there is not a lot of data from prior studies supporting this and that a concurrent but smaller study didn't see that, it raises the question. But I think it can't be dismissed out of hand. And certainly there have been other studies that have shown associations of bleeding and mortality. In the DAP trial, they looked at the data and found that there seemed to be an imbalance in cancer-related deaths. Whether that was misfortune because of more cancer patients randomized into that arm or not, I think it's hard to say with certainty. So I would say that I'm somewhat skeptical of that result, but I always keep an open mind when it comes to an important result like that.
Well, thank you so much for those thoughts and discussion of this exciting and interesting clinical trial. I believe that we do have more guidance on how to take care of our patients with dual antiplatelet therapy after 12 months. However, there are some questions that remain open, and of course, clinical decision-making needs to be made and individualized for every patient. So thank you very much for joining us today, and really appreciate it.
All right, my pleasure.